Oh, hi, Dr. Carrico. How are you?
Fine, thanks. Nice to
That's
meet you.
good. Nice to meet you too. Thank you so much for joining me. I want to be respectful of your time, so we, we appreciate so much you taking a minute to talk to us. I'm Lawana Brown. I'm one of the program directors for Regis College for the Women's Health Nurse Practitioner online track, and it's
Great.
such a privilege to be able to talk to someone with your background, given
Oh,
our current climate.
I'm
So
thrilled to death.
I just want you to take just a minute and kind of give us a little bit of your nursing background and how you came to nursing so that that'll frame the conversation for those who might be listening.
Okay. Well, let's see. I have been a nurse since 1976. I went to a diploma program and have gone on from there. Have my BSN, I have my master's in health services administration, a master's in nursing, a PhD in management in the health administration, and a DNP. So I love to go to school. So it's great. I love to learn. That's wonderful. I've been in infection prevention and control for about 30 years. I've had an amazing mentor both on the infectious diseases side and a number of excellent mentors in the field of nursing. So I feel like, I've had an amazing and wonderfully blessed career. And I'm hoping that I've got another few years left in me because I sure am loving it.
Well, that's wonderful. I love it when nursing is just like we can see that it's such a passion and joy for you. So that's
Yeah,
great.
love it. Love
So,
it.
being that your background, deals with infectious medicine and infectious disease and all of that, talk to me a little bit about what that looked like. For those of us even that are nurses,
Okay.
we had a view of infectious disease and all that was there before, but we wouldn't have had the knowledge base that you had coming into this. So talk to me about January of last year, December 2019, what that all was looking like and what you knew that we didn't know possibly, Dr. Carrico.
Well, it was interesting because November of 19, was it 19 or November? I don't remember. November before the December of the
Mm-hmm.
pandemic.
Mm-hmm.
I was invited to Wuhan by the one of the provinces, kind of the Chinese CDC for that province, to come and present at a conference about environmental infection control. So I didn't really know, I thought, okay, this will be great. I got there. It wasn't like what I expected. It was more like tell us about the US and how you do this and where are the guidelines and what are the guidelines and who decides what. And so a lot of more intense interaction than than I had envisioned. And while I was there, I went to they took me around Wuhan, went to the open air market, and they're like, and over that way, behind those buildings a while, there's our big biosafety lab. So it was an interesting experience because at that time, that was November before we started reading about the problems with the coronavirus. So once I returned, then we began to hear more and more about that. And, since December, I guess it was December of 19, nothing has been the same. In late February, we began to see, of course, get more feedback about the cases that occurred in Wuhan, and that the publication that talked about the impact of nurses specifically in Wuhan that were impacted by this novel infection. And then we saw the same thing happening on the West Coast in both hospital and long-term care. So by March, we knew this was serious business, and we began then to look at how do we, at least from my perspective, my group, our big concern was how do we protect the healthcare workforce? That we have people that are going to be in healthcare facilities trying to address this new infection. We didn't have a test for it.
Mm-hmm.
We didn't understand it. We didn't have a treatment for it. And we began to see then nurses becoming sick, and then unfortunately began to see deaths. So in March, everything changed.
Mm-hmm. You're
And
exactly
our
right.
focus was on what do we need to start getting out to nurses? What do we need to do with respect to improving basic infection prevention and control practice? And then we began to see the impact in long-term care, where we had, in essence, ignored that part of the healthcare industry. It was unfortunately the perfect storm. and without, combined with just-in-time approaches for supply chain and supply management.
Mhm.
Now we had then a new, a novel virus. We did not maintain adequate supplies of PPE. We did not even produce the PPE in the United States. So, all of our weaknesses were all exposed simultaneously. And that, brought a renewed interest, at least in infection prevention and control. Now, that's the good news. The bad news is, I've got this great cartoon that says, oh, isn't it interesting that people that were constitutional experts last month are now infectious diseases experts this month? And that's exactly what has happened. So we unfortunately have a lot of information, flooding not only social media, but academia, and only a portion of it is correct. Again, we're back to the issues that we have with teaching not only our students, but also improving routine practice, so that not only do patients get ideal patient care, but we make sure that nurses are not harmed in the process of providing patient care.
And I think you saw that. I know that you saw that coming, because I saw the 10-minute video that you did in January of 2020 on Facebook, where you sat down and basically said, listen, nurses, we're going back to, you got to identify these patients. You got to hand wash. You got to be responsible for what's going on in your area. Don't just let housekeeping be the one. You went through all the different things that we needed to be reminded of in nursing to, and this was in January. So, like you said, being the expert that you are, you could see a lot more than a lot of the so-called experts that have come on since that particular time. Talk to me a little bit about what's happened specifically in Louisville, with the nursing situation there. Were there shortages? And again, we've been in this over a year now, but we're kind of almost circling back to where we were last summer almost. So talk to me a little bit about what it looks there where you are.
Well, back in early 2020, as we were just getting testing going, we, at that time, public health was the only one that had access to a test, and they were limited. I think across the U.S., the state health departments could do like 20 tests a day. It was ridiculous.
Mm-hmm.
And so, we have a biosafety BSL-3 lab, BSL-4 lab here in the community. And so we worked with the biosafety lab to say, can you guys get reagents? Can we start doing, this would be tests just for surveillance. These would not be FDA approved tests, but can you get the CDC reagents as part of that biosafety lab network? And then use some high throughput testing capabilities so that we can start at least looking for this and seeing where it is. Mm-hmm. And how do we provide that information back to healthcare facilities so we can make sure that nurses and others know what is going on in their facility, and then drive the need for PPE use. Mm-hmm. So we began doing that testing. We worked with Luminex to actually develop and get an approval for a test that we could then use this process to validate this high throughput kind of academic or research testing. But we started, testing about 500 tests a day, and we were trying to get to a point where we could look at anybody that was symptomatic at all in a healthcare facility. Can we test them, and then push to anybody at all that is admitted to any facility? Can we test them? Mm-hmm. So that we could begin to look and see what was present. And then in doing that, we were having daily calls with all of the area hospitals, and we were trying to get enough reagents so we could start testing in long-term care. And then we began to have daily calls with the medical directors, so whoever was seeing, there's a gnat in here, sorry.
Oh, no, that's okay.
But anybody that could influence and communicate with the patient care staff. And what we did, ended up doing is we were coming up with recommendations. Like, we came up with the recommendation that we need to start universal masking in all healthcare facilities. And we did that, I think 3 weeks before CDC came out with the recommendation. But we were seeing healthcare workers become ill at a faster pace than others. So we knew that we could not say, well, this is community exposure.
Exactly.
We knew that just with the case control and just doing a regular old 2x2 table.
Exactly.
What was going on. And so, the transmission was happening in the healthcare setting. So we were saying, you've got to wear a mask from the time you walk in the door. Everybody needs to be wearing a mask. And then starting to look at, environmental things like, are you looking at bringing in fresh air? Can we dilute what may be there? So starting to do a lot of the environmental interventions well before they were mainstream, because we were trying to pull the nurses and individuals across the healthcare facilities. And this didn't involve competition. Like we weren't,
right.
Your health system, my university health system.
Now, there was a sharing that occurred.
Yeah.
Unlike anything.
Right. We're trying to keep our healthcare workers alive.
Mm-hmm.
And, we had a lot of pushback from, our state government, who wanted to do, oh no, we need to test the community. And we're saying, we don't care what's going on in the community right now. If we don't have enough tests right now, we don't need to be out searching for this in the community. We need to be protecting the nurses right now. Mm-hmm. So we were very vocal. Actually we were somewhat insulting of our state government in saying, we know that your suggestion is based on politics, plus or minus ignorance. Mm-hmm. So we're not doing that. We're not going to have any part of this testing because people are clamoring to be tested when we don't have enough tests. Now, it'd be very different if all of a sudden we have enough tests, then we go along. But, we were really pushing for, and that was really our sole focus was, keeping our healthcare workers alive. And how do we have the nurses want to come back to work? If we're not protecting them, why would they want to come back to work? So, this was, and we were looking at, yes, we're concerned about the physicians, but if you're in and out of the room in 10 minutes, you're not the one at greatest risk. Mm-hmm. It's going to be the nurse that is at the bedside. They are the ones at greatest risk. Right. So, we were singularly focused.
It's fortunate for them that you were a nurse and had that background to know that, and to realize the importance of protecting them. And I like that you bring in the political folks, because there is a lot of political, things that have surrounded these issues, but overarchingly, the issue needs to be, protecting healthcare workers and protecting, the patients in public. And so we have to put those things aside. As we moved closer to a vaccine, which we all were watching. Talk to me a little bit about the conversations that you had surrounding that. I know that even in my own community, there was a conversation that occurred with the public. There was conversations among healthcare workers, and there was some parallels because, there's always that thought that, the vaccine came too quick, and people always have kind of had a little bit of a leeriness there. What has your experience been in the conversations that you've had at the level that you are to be able to look at the vaccine as it was coming on board?
Well, I think we took some really unique approaches. Number one, we began to have open Zoom discussions about what's happening with vaccines, what are the different vaccines, how are they developed, what's the clinical trials process, how do you even get a vaccine, that is able to be tested. And then when we had vaccine that was released as part of emergency use authorization, we have in Louisville, we were doing a drive-through vaccination back in the early 1990s. I think we were the first place in the United States, at least according to CNN, we were the first place.
Wonderful.
So we had some experiences with drive-through. So our local health department took all of the plans that we had, and they adapted them to provide drive-through in an inside arena. So I worked with the Kentucky Nurses Association. We recruited nurses, physicians, pharmacists, and others that were either retired or could volunteer. And we developed then a drive-through process where we would vaccinate about 2,000 people a day. And ended up, I think we were in operation for 17 weeks and vaccinated about 110,000 people until enough vaccine was available that people didn't have to come to a mass immunization site.
Mm-hmm.
So we trained, we provided clinical opportunities for students so that they could get back into having some patient interaction. We would have 3 orientation sessions a day in kind of 3 shifts. Everybody would work 3 or 4-hour shifts. And I got 2 biosafety cabinets from the university to be donated for use, so we could prepare vaccine under a hood, in a biosafety cabinet, because an indoor arena is sort of like a big giant garage.
Exactly.
So we began to host people from all over the U.S. coming in to say, how are you doing? How'd you set this up? And we had written procedures and training and so forth. And by doing that, I'm convinced, I'm not sure that we have been able to capture the impact, but when we had about 4,000 volunteers, and we had volunteers not only in the kind of the administration, administering vaccine, but we also had people that were directing cars and, in the post-vaccination monitoring area, and people helping with computers and all that. So we had a broad group of people across the community, not just healthcare workers. And I feel like when we had those people involved, they were seeing the process. And I think we built vaccine confidence in that method. We may not have been able to address some of the vaccine hesitance issues, was it developed fast, and, those types of questions, but we made people confident that there were knowledgeable healthcare workers that were involved in doing this and being vaccinated and helping others be vaccinated. So I think we positively influenced the community. And across our community, I think we have had higher rates of vaccination than we have had in other similar sized communities. And I feel it was because of this, because of how we engaged the public. And we spent a lot of time working with the teachers. And, we had specific media things. And for example, we have a picture, one of the nurses vaccinating a teacher, and she's the teacher is sitting in the chair and the nurse is kneeling by the side, giving the vaccine. And it's almost like we're here in service to you, we wanted to convey these images of service and concern and, within the context of leadership, so that we could then, engage people that this is not something done to you. This is something that we are doing together for each other, and trying to get around some of this, the unfortunate, the politicization of this process from both sides of the aisle. It's not just one, it's both.
Right.
And we have also been, tried to be very inclusive in our approaches, that it's not just all old white ladies, like me, that we are across the board in who we care for and who cares for others, and how we view our community as important across the board.
Right. So. And that's very important. That's amazing, that you all were able to do that. I love that term, vaccine confidence. I'm going to steal that, because we definitely do need to have that. And also the fact that you mentioned that they're, being able to see somebody that looks like somebody, in your community, it makes a big difference, because those communities that are disenfranchised are going to be hit harder by everything.
Absolutely. We've, so much in dealing with, just generally dealing with poverty, and how all of this, all the things that we have neglected, now it's all come back all at the same time, to say, if you do not cherish and value each other, then you will continue to ignore and diminish and disenfranchise each other. And you may think that what goes on in Vegas stays in Vegas, that only applies to Vegas or that commercial. And that, this will come back around to us as we care for each other. And if we do not care for each other, then this this is what happens, right?
This is true.
We're
This
living
is
proof of
true.
this.
And it's funny
Yeah.
because the sisters that founded Regis College, they based it on the care of the dear neighbor. And at no other time has it been more evident that your neighbor truly is your keeper, because whatever's going
Absolutely.
on there is actually going to feed over to you.
Yeah,
One
yeah,
point
yeah.
I do want to ask as well, I know that in your video that you did when you talked to the healthcare providers, one of the things you mentioned was the importance of healthcare providers being vaccinated. And unfortunately, there are some healthcare providers, even some that may be working COVID units in other areas that have chosen for various reasons not to get vaccinated. We respect, of course, everyone's right to choose, but is there a way that we can speak not only to them, but even to the general community? Because at this point, we're probably at a tipping point with vaccines where we're now working more in kind of a presenting evidence, persuasive, fighting misinformation to get the remaining folks. There were a few of us like me that were lined up, to get theirs. And then, now we're on the other side where they're not lined up and we're trying to go out. What would be your approach, Dr. Carrico, you think that we need to do to make that more happen,
Well, in my family, I've had a lot of soldiers. So my husband, my brother-in-law, my father, everybody was in the service at some point. So I agree and will fight for the right as an American to choose my liberty, my autonomy. And so I view this as one of those issues that I respect and I understand someone's desire to be in control of themselves. The issue is you, at what point do your decisions then harm someone else? And so you can still make that decision from my perspective, but you can't work in healthcare.
Right.
And so we cannot accept your choice when your choice directly, we know from the evidence, can harm the person that is depending upon you to provide them with safe care. So someone can still choose to not be vaccinated, and I will support their ability to choose. I want their choice to be based on information. I want it to be an informed choice and accurate information, informed choice, right? But if you still, view that in the balance, you feel like your risk, is with the vaccine is greater than your risk of disease, then you can't work in healthcare because clearly your risk of coming in contact with this either from a patient or outside and hurting your patient, now the scale is tipped. So I think we cannot accept in healthcare a healthcare worker that is unvaccinated. I don't see how ethically, I don't see how we can.
Yeah.
So then our goal is, I want you to be happy. I want you to love life. I want you to be able to do and what what your heart tells you and where your convictions are. So let's help you find where you can safely be.
Yes.
And then at some point, if they make a decision, it's just like, at church, you always extend the invitation at the end of the sermon to invite you to come forward to the altar. We will always keep that invitation open, that there will be a place that you will never be shamed and, diminished for your decision. We will always welcome you to be vaccinated. Until that time, no, you can't kill your patient.
Right. Yeah, because I know that the era that we've entered now with medicine, we've turned a corner that we're not going to turn back. I mean, we're here, and I think we're going to be continuing in this pathway. I was saying yesterday with another nurse that I talked to that I can't envision now. Initially going to work with the mask seemed really now I can't envision ever being able to step into my health center without having a mask on.
It's crazy,
because
isn't it?
it's
so
become
much has changed, but
it has become a part of the norm, and we do have to find that balance. We respect, of course, everyone's right, but still we have to have mandates that will protect us. Even with our students, we think not everyone's vaccinated, but please put on a mask. So at least we have something that we're doing to care for each other, because that's really important. So before we end, the one thing I want to ask as well, I always ask nurse educators is, we are moving, forward through the profession. I'm about middle of my career, even though I didn't start nursing till I was 36. But, we have a group of nursing that's kind of moving out, and we have these new nurses that are coming in that we're educating. So we're teaching them the things they need to know, but this is a whole different era here. How do we frame this so that it benefits the nursing students that we're training now and helps them as they move forward to care, not only for the patients, but also at some point for us, in the future, what are the things and conversations we need to be having as educators with the nurses that we have now?
Well, I think it's interesting because if you look at public health theories, why do people do what they do? And almost all of those theories are around, I do something to me or for me because I have a perceived, there is some perceived value or benefit to me. Mm-hmm. In healthcare, we are asking someone to do something they may not want to do. Anything from, you may not want to work night shift, you may not want to work Christmas Day, you may not want to get rid of artificial nails, you may not want to wear a respirator. We're asking you to do things that you don't want to do, but it's for the benefit of someone else. And so somehow in our process, how do we reinvigorate or reinfuse the caring for others? And I think we have lost that. Mm-hmm. Not just recently, but I think over time we've become less concerned about others, more concerned about self. We hear all the time, our children, they're our candle on our table, we have to, everybody wins a trophy. Our whole process has been much toward, self-gratification and, I'm number one. Mm-hmm. Well, how do we reverse course? And I don't think it's going to be an easy, because we're trying to turn the Titanic, right?
Yes,
the cruise ship,
You're
and it's going to take a while to do that. But I think then that both in terms of our, discussions on who enters the field, don't enter it because there's job security, enter it because you care for the person. Mm-hmm. That you are going to be taken care of. So, our discussions about what does it mean to be a nurse, our discussions about, professional ethics and all of that, I think are going to have to be reframed. And, part of me is a little bit concerned that right now we are moving, we're entering this age of inclusion almost to the point of anything anybody wants to do is okay. Mm-hmm. But in healthcare, is that really what we need to be saying? So I think, we're going to be confronted with what does this mean to the profession? And how do we say, despite everything else, caring has to be number one, that the biggest constant in your equation in order to be a nurse has to be your patient. You have to be willing to do what you need to do because you have that servant care, that love for somebody else other than yourself, and that type of value. In order for that to be present, we've got to nurture that. So we may get to a point where we have people that don't go into the profession because of that reason. And then we have issues with, before, if somebody said, Ruth, somebody called in sick and we need somebody to stay and work nights. Well, of course I would, because I would think, who's going to take care of the patient if I don't stay? Right. If that's not my thought process, then it may be, that's somebody else's problem, not mine. So,
it's going to be a difficult balance because, we have that, but we also have the self-care kind of thing that we want you to have the self-care, because we definitely want the nurses to have that space, but you got to balance that as well with the patient care. And also another level is that if we want our nurses to have patient focus, we've got to get the hospital healthcare administrative to switch that focus to patient. I read someplace the other day that instead of healthcare, in some cases we have wealth care, because it's driven more by the finance, the revenue, and those decisions sometimes.
Always. Otherwise, why in the world do we have electronic medical records? It's not to help our documentation,
exactly.
Right? It's to bill. And
you're right. So it's got to be a shift that's going to occur. But we can only start with where we are, which is with the nursing students. So trying to infuse in them that care, and then to, not everybody who wants to go into nursing should be a nurse, and that is, it depends on your reason why and the things that you want to do. And like you said, sometimes your place that you need to be may be a different area in healthcare than nursing, depending on what your overall goal is. Well, I thank you so much, Dr. Carrico.
I've enjoyed it. We'll fix this problem because I'm at the point where I'm going to need healthcare even more.
Oh, yeah, that's right. And you're going to want to know that the person that that turns the corner is not just, competent, but also caring, that they know what they're doing, but they really care about you. So that's a big deal. Thank you so much for talking with us. We wish you so much success in the work that you're having there in Louisville. And we certainly were so happy to have a few moments to talk with you.
Great. Thanks. It was a great
care.
opportunity. Take care.
Bye-bye.